Chairman Baucus, Ranking Member Hatch, and distinguished members of the committee, it is an honor to testify before you today. As was mentioned, I am the Chief Executive Officer of Health Services Business of Siemens Healthcare, Siemens being a leading medical technology company with a portfolio comprised of medical imaging, laboratory diagnostics, and healthcare IT. Health Services develops enterprise-level healthcare IT solutions that help providers coordinate care in a variety of settings, including hospitals and physician practices. We are pioneers in the HIT industry, having served our customers for over 40 years. Now, before joining Siemens about 3 years ago, for 20 years I was a CIO in a large healthcare system in Boston, so on the implementation side of electronic health records, provider order entry, and interoperability. So I've lived those battles and those accomplishments. I also spent a year working for David Blumenthal as a senior advisor and involved in the early formation of the Meaningful Use Stage 1 criteria and the formation of the grant programs that led to HIEs, the regional extension centers, et cetera. Now, Siemens applauds the committee for holding this hearing to highlight the importance of healthcare IT as a tool to improve the delivery of care. We also appreciate the work of Senators Roberts, Enzi, Thune, and Burr for their published report, Reboot, re-examining the strategies needed to successfully adopt health IT. Today's IT solutions, as you know and you've heard from and cited in your opening comments, have a wide variety of abilities to improve healthcare, reducing errors, improving the efficiency of the delivery of care, and overall elevating quality, such that the care that we deliver to citizens in this country is dramatically and materially improved. We are fully committed to helping our customers achieve the objectives outlined in the EHR incentive program. The program was thoughtfully designed and has been quite effective in a number of different ways. We all can point to the significant increases in the number of hospitals and physicians that have attested to the program, and I'm sure that Dr. Mosashari and Conway mentioned that and covered that in their commentary last week. However, I think the program is reaching an inflection point, and these are some comments drawn from the multiple perspectives that I have had over my 30-odd years as a career here. I think the requirements for Stage 2 are more stringent, and there are a number of complicating factors, such as delayed delivery of testing tools, confusion over criteria, and inconsistent auditing approaches. Optimizing EHR technology is a fundamental element both in the episodic treatment of an individual, but also in the care delivered to them over time and over multiple venues. Implementing an EHR is a massive undertaking, even for our most sophisticated of providers and health systems. For small, rural, and critical access hospitals that do not have adequate financial resources and staff resources, it may be on the edge of impossible. So we run the risk of creating and exacerbating a have and have not series of systems and providers, those who are able to use the technology and those for whom the technology is outside of their reach. Further compounding this, in the next 15 months, healthcare organizations, in addition to Meaningful Use Stage 2, are dealing with the mandatory and massive overhaul of their systems and operational processes that result from ICD-10, and in addition, their own strategic and operational needs and challenges to prepare themselves for payment reform, new care models, and other changes that will be coming in the years ahead. We may be creating a perfect storm that has potential to overburden eligible hospitals and providers of all sizes. Hospitals and providers may choose to opt out of the program. There is evidence of this, as more hospitals and providers have indicated they will not attest to Stage 2, and fewer rural and critical hospitals participate at all. We could arrive at a situation in which the participation rates that we've seen to date in the Medicare portion of meaningful use represent a plateau rather than a point along a greater journey of adoption. And this we would not regard as success if we actually have at the end of this program a minority, a significant minority of participating institutions. More so and moreover, many hospitals and providers are rushing into their implementations. They are trying to say, I've got 15 months to get this in. I also have to do ICD-10. I have to do this and that and do other. I'm going to get it in and get my check. And in the process of that, they are shortchanging a lot of the process, re-engineering, and clinical engagement work that needs to occur. The result can be is that we will look back on the $19 billion or whatever we wind up spending on this program and say, what did we get in terms of care improvement, and be quite disappointed with the results because the time needed to change the healthcare system was not taken because there was no time to go off and do that. Similarly, we could wind up in unsafe conditions where because of hurriedness, the workflow changes were not done as well as they should have been, nor was the training done as well as they should be. Therefore, I propose a couple of recommendations. The first is I would give hospitals and providers the time needed to properly and effectively implement electronic health record systems. It is a complicated task that involves every aspect of care in every department in the hospital and in the outpatient setting. It takes a lot of work and a lot of re-engineering. I'd recommend that you extend the Stage 2 deadline until October 1st, 2015. Those who can take advantage of it in the time frame 2001 to 14, fair enough. Those who need more time, give them the time to do it right. This will give them the time to accomplish what we want them to accomplish. The second is I would modify the program to be less prescriptive and more flexible by, for example, providing a menu of requirements with a minimal set that must be met rather than all of the current 16 requirements of Stage 2. The ones that I would keep would focus on interoperability and give them more latitude regarding the remaining set. This will allow providers to select those requirements that reflect their own strategic and operational objectives in terms of improving their care and their quality and the service that they provide to their community. The third thing that I would do is have the Stage 3 meaningful use requirements support the transition to new care models and reimbursement by placing less emphasis on feature function and more emphasis on our true goals, improving care outcomes. Fourth, would consider provisions for rural and critical access hospitals, such as grants, loans, and advance payment of incentive monies to enable them to better finance the undertaking and the journey that we would like them all to engage in. And then last but not least, would strengthen the program to focus more, with more vigor and more force on the interoperability to achieve the development of standards and the enforcement of the standards. I realize, as mentioned by Janet, that a lot of this involves the business case. That being said, we can be more aggressive and more effective at getting the standards into the industry and ensuring that they are complied with. I've run out of time. I have a brilliant closing, but I won't use that at this point. We'll save that for the comments. Thank you.
Thank you, Dr. Glaser. Look forward to your brilliant closing. You put a lot of pressure on yourself. We're getting